Good afternoon, everyone. Can you hear me okay? I'll try not to shout out, otherwise it'll clash with that. Okay, so my name's Ruma. Just a little background about myself. I've been a pharmacist for about 15 years. I started off working in hospital and then moved over to CCG and now work as a clinical pharmacist who works in the practice as well as for a federation, Newham Health Collaborative, based in Newham. And before I start the talk, my talk is really just to give you an overview of what clinical pharmacy is in primary care. Before I start, I just wanted to get an idea, just the show of hands, and if anyone can shout out to me really, what do you think pharmacists do? It's a bit general. Medication review, anything else? Audits? Sorry? Seeing patients. Yeah, brilliant. Thank you. And does anyone know what sort of qualifications a pharmacist needs to become a pharmacist? Yes? MSc pharmaceutical. Anything else part of their training to be qualified? Sorry? Sorry, I can't really. Degree in medicine? Okay. And what sort of sectors do you think pharmacists work in? Hospital? Sorry? Community? Research. Okay, thank you. I'm going to try and get this to work, okay? So give you a background in terms of what pharmacists need. So in this country, it's a master's degree, takes 4 years to complete, and you need 1 year sort of registration, practicing across sectors you tend to, and then you have a qualifying exam. If you're an overseas pharmacist, depending on certain countries you come from, you may have to come back and do another year at uni and then go through the pre-registration year. Pharmacists can have BScs, and certain countries, they have doctorate as well. But to register, again, they will come back and go through this process. In terms of what sectors, our degree is very much a very scientific degree, and it goes from sort of pharmacy practice all the way to drug, identifying them, discovering them, all the way to formulation and design. So when pharmacists leave university, they tend to work in an array of sectors: industry, hospital, academia, community, and primary care. Most people know pharmacies as community care and now sort of in hospital. My talk will focus around primary care, but mainly clinical pharmacy. But I don't know if many of you are working with pharmacists at the moment or will definitely be, but traditionally when pharmacists did work in primary care, it was mainly in CCGs around sort of medicines management teams where the focus was mainly around the prescribing budget. So you may be familiar with pharmacists coming and saying you're spending too much on this, or these are high-cost drugs, hospital-only drugs, so those sort of areas. So now the branch in terms of clinical pharmacy in primary care is either a practice-based pharmacist, and from this year onwards they have network-based pharmacists. So I'm just going to touch on that a little bit more. Before I do, I just wanted to highlight where this has actually come from. You okay? You can still hear me okay, right? Brilliant. So as we are all aware, there's a national shortage of GPs. In 2015, there was an NHS England pilot programme, which the whole idea behind it was to try and integrate the role of clinical pharmacy in general practice. It was actually really successful. So in 2018, they rolled it out to a nationwide programme. And they realised the actual impact that pharmacists were making. And so from 2019 January, the papers came out with the desire to have primary care network pharmacists, and they've incentivized that for the next few years for general practice to recruit. And the vision for pharmacy is over the next 5 years to try and have a pharmacist in every single GP practice. So what sort of skills can clinical pharmacists actually bring into general practice? I've listed a few, and okay, I've got to quieten down now as well. Going to adjust a little bit. So I'm going to sort of run through, but you will have these slides. So I know the writing's a little small. So some of the areas that you mentioned about medication reviews on sort of long-term condition areas like diabetes, asthma, COPD, hypertension, and a little focus on our own skill set around drugs. So we're looking at sort of safe and effective use of medicines. So areas like managing and supporting repeat prescribing, high-risk drugs, polypharmacy, care home work, if there's a care home linked to the practice. You have sort of Public Health England campaigns. Pharmacists are also involved with triaging patients and sort of reviewing minor ailments. A lot of community pharmacy deal with minor ailments, but obviously the setting is different when in a GP practice. Also work around sort of education and training for practice staff on clinical areas. It doesn't need to just be a role for GPs to do. And work around quality improvement and CQC support work, because there are domains around safe and effective which fall under prescribing as well. And overall, supporting, again, with cost and effective prescribing, because pharmacists are familiar with alternatives that are around and sort of up to date with national guidance. I would like to stress, because many of you will work with pharmacists now, it is a very individualized role, and it is based around the needs of the practice as well as the desire of the pharmacist, really. Just like practice nurses, because you might have your own specialist interests and you might want to develop that, but sometimes it is a balance between the GP practice and the practices you work with as well as your own interest. So just a summary, the idea is actually meant to be a more patient-facing role this time, as opposed to sort of a lot of background work that pharmacists traditionally do. And it is to try and increase patient access, reduce waiting time, reduce A&E burden, and help with secondary care, just like everybody else is trying to do. So I want to just explain the difference between practice-based and network-based. And it really is a small difference. So when it's a practice-based pharmacist, we're looking at, when NHS England mapped it out, they're looking at one pharmacist for like a 15,000 patient list size. And for network pharmacists, really about the pharmacists covering the whole population, so it's 30 to 50,000 patients. The training program really is very similar for both pathways, and it's an 18-month program, depending on your experience. There are modules, and the idea is to have your non-medical prescribing, the independent prescribing, either after or within it. And some pharmacists might actually come in already a prescriber. You might wonder, why is it 18 months and why is it such a long training program? Well, as I mentioned about the different sectors the pharmacists work in and the background, so you will meet a pharmacist, everybody thinks, oh, okay, we're all the same, but the level of experience will really make a difference. So if you've only ever worked in hospital, you're going to be very comfortable clinical, but your consultation skills and other aspects of working in a team, although you work with MDTs in hospital, is very different to in a small setting. Just like if you've come from community, your clinical will be very different. You're not used to dealing with and questioning sort of the drug therapy with the doctors as much as, because you're dealing with mainly repeat and chronic illnesses. So this 18-month program really allows for the pharmacists to kind of have a little platform and standardize their training, so that at the end of it, everyone has a good understanding of what primary care is, because it is so new. And the last point to make is a practice pharmacist probably work between 1 or 2 practices, probably maximum 3, and they might do a range of activities, meds reconciliation, discharges, things like that, whereas a network-based pharmacist may work across 4 to 7, up to about 7 practices. And their work might be much more focused and to deal with large-scale work. So these are the difference. And you might see some pharmacists, you will definitely see both actually, because that's the way the plan is for pharmacists at the moment. So in terms of just the summary again, the benefits. Our expertise lie with being experts for drug therapy, safety around medicine. So really our knowledge and benefit of harm and drug to try and get the maximum benefit and minimize the harm. And we do that through looking at drug interactions, looking at how drugs are cleared through the body, be it the kidney, liver, and we try and look at the dose adjustments that are necessary. Drugs in pregnancy, children, elderly, and a lot of treatment around sort of non-drug therapy as well, so around compliance and adherence. So many times patients are quickly escalated, oh, blood pressures, okay, let's add on. Doctors will easily increase, but if the patient hasn't even been taking it, this is so common, isn't it? So investing time, when you're doing medication reviews, actually, sometimes people are like, half an hour medication reviews, and doctors are like, we take 5 minutes. But it's because you haven't empowered the patient, you haven't gone through to find out actually what's happening. And we're actually seeing a lot of that now as pharmacists are coming in. So now I'm just going to focus on sort of areas that we, pharmacists, healthcare assistants, nurses, where we can all work together. And some of the sort of routine, I know like Sam touched on a lot of the work that nurses do. So when I go and work with myself, I know they don't just do the smears or just do the EMs. They're seeing everything, long-term conditions, the lot. And there is an overlap in our work. And I think that's great because we can both support each other. So even with the long-term reviews, you've got patients who are like diabetic, asthmatic, you're a little stuck on, even if you're a prescriber, so what? We're all sort of learning. You can just book the patient then to have a further review for the pharmacist to optimize, because then they can really go into detail with it. At least, you know, we're continuing the care. Other areas, like I do new patient health check for my practice. I don't do the 40 health check, the new ones that transfer between practices. And I said to them, why don't you send all your medication aspect to me? Because that takes time, and it's so important when they transfer it over to have an accurate drug list, because a lot of time you see literally they come and they just restart the medication and that's it. You've lost them. You've lost the chance to deprescribe. You've lost the chance to review. And none of us have the time. So as nursing colleagues, just book in with the pharmacist. Another area that I have quite a keen desire to sort of continue supporting the nurse in my practice is doing sort of joint clinical meetings. It doesn't have to be the GPs that lead on clinical meetings. If we together identify our practice is really struggling with asthma, dealing with asthma patients or COPD patients, let's make sure our learning is around this. And collectively, if we work together, you're a stronger force then, because obviously we will be challenged by GPs, but I think when we come together, if we have a common interest to upskill ourselves and our knowledge, and we can do that by leading on these things. And so I mentioned about audit work. We are actually trained to do audit work. It's part of what we do. Even when we're qualifying, you have to do audit to always demonstrate outcomes and improvement. And this sort of work is really great for CQC and CCG incentive audits. But I think it's you can work with your pharmacist, and many of you will know how to do audits, but to sort of help upskill you. And I think it's really important that one profession, there's so many of us coming in to the sector now, that we shouldn't come in and de-skill another profession. So you may be that, okay, I can do audits, no problem, but then you've got pharmacists coming who can do that better because they've been doing it for years, but then that will de-skill you, and you need that for your own appraisals, your own improvement work. So working together, I think, I've listed them so you can look back just to give you some ideas. And I actually wanted to touch on my own experience. A few years ago, when I was doing my independent prescribing course, I couldn't have done it without my nurse colleague, because although I had my GP who supervised me and supported for me to get through it, literally without using the template so they can get the cough points. The GP is not going to sit there and say, make sure you take this, make sure you do that, because you're going to miss it. It really helped me increase my confidence in consultation skills as well as like physical assessments. Pharmacists do not touch patients. We are not trained to touch patients. So although it's getting easier, it's very uncomfortable for us to come in and say, oh, can you take your shirt off? For me, can you take your socks off for a diabetic foot check? I was like, oh my God, how am I doing that? It's really awkward for us. So I know these are sort of subtle skills, but we're going to need help. And so it's great. So at the beginning, when your colleagues do come in, if you lend your support, you'll find they're opening up and saying, actually, let me help you with this, come to me with that. And that's how we're going to be able to sort of bypass the GPs and work together. And recently, one of the nurses, actually, she did her prescribing after, about 3 years. And then she's come to me saying, I don't get kinetics, pharmacokinetics, because it's on the course. Pharmacology, I'm lost on and prescribing. And I was able to help her, sort of pay her back, but help her for how to implement it in practice. Yes, you learn theory, but how is that making sense with the drug? And, you know, establishing that rapport just helped us both. And I'm sure now she's moved on, she's not going to have any fear of working with a pharmacist. She knows how to tap into our skill. And just to finish off with, really, what is the end goal? The end goal is, if we all work together, I think the practice, if we work together as a team, the practice will be successful. We need to respect and value each other's sort of skill set, and looking at ways to tap into the different skill set. That's the key, not just, God, another person come, we've got to train him up, got to do this. This is, the reality is this is what everybody's feeling. I haven't got time. But investing at the beginning, and we all know when we go to a new job, the first few months make such a big difference. And if you don't support people like that, they're either going to leave or they just build up that wall from the beginning. So please, I know you guys are really busy, and I've worked across 7, 8 different practices, and I know first thing I do is I go and try and make friends with my nursing colleagues, because I know the difference it will make. No, I just wanted to add just something actually on my, moving on from this, but when I worked in hospital, there was, I think one of the GP, the doctor's training manual, I think top 10 things was, make your pharmacist your best friend, because they leave university with 8 weeks of learning about drugs. They can't even prescribe amoxicillin, BD, once a day. Junior doctors avoid them the first few months, that's all I say. But seriously, on their support thing was be a friend with your pharmacist. And I always, even in hospital, used to tell my juniors, be your nurse's friend, because they know the patients. They know, they're working with them much closer than we are. And it's the same thing. I think when we go out there, people don't realize the amount you guys do. I know I do, and I am passing that on. So my last thing is different skill set, different perspectives will enable all of us to provide the best care for our patients. That's me. Thank you.
Thank you, Rima.
Hi everyone. My name is Charmaine. I'm a physician associate. I've been working in general practice for the past 2 years, and I'm just here to give everyone insight as to what physician associates do. I know there has been some concerns, I think even from when I was training till now, about people think that we might be taking their roles or trying to replace them, and I'm just here to say that that's not the case, okay? So at the moment, what physician associates currently do, we do face-to-face consultations, and the time that we take will vary depending on our experience. So I remember starting on 20 to 30 minutes, and now I'm between 10 and 15 minutes. We also do telephone triaging and telephone consultations. We read results, do referrals, we do long-term conditions, and we are sometimes head of specialities in general practice, as are many nurses. But this is just what physician associates can do. It's not necessarily they come into general practice and come into hospitals and are expected to do all those things, because that doesn't make sense. Our initial interaction with patients were positive and negative initially. Obviously, we all know how hard it is to get an appointment with our GPs. I myself is still waiting up to 6 weeks to see mine. But because we have now all these other roles that can also see patients, it will bring down the waiting times. So like I've put over there, most patients are just happy to be seen by someone. We do explain to them that we cannot prescribe, but we can initiate medication, and they are happy that our prescriptions are sent electronically, or they come and collect it later, or we print it out and someone signs it for us. And they're happy for us to discuss their conditions with doctors or other clinicians if we're uncertain. Obviously, there are some negatives. Some patients still don't understand what we do, so therefore aren't happy for us to see them because they feel like their condition is too complex, that we lack understanding. What I've learned so far in my role is that always try to learn more. Always ask if you're not sure, and always try to discuss everything with everyone. So in my previous practice, which I worked with with Halima, we had weekly clinical meetings where we can manage the case, and then we'll take that feedback back to the patient. And what I want to emphasize is that physician associates thrive from learning from their other colleagues. That's what we're coming to learn. And without working with nurses, nursing associates, GPs, we won't develop any further, because our role is focused on bridging the gap. So it could be that a physician associate at your practice is used to deal with patients' minor ailments or acute patients, or it could be that you have so many long-term condition patients which nursing staff can't manage by themselves. We just fill the gap so that you don't feel overwhelmed. So we're not here to take anyone's role or step on anyone's toes. We're just here to help and bridge the gap. And the last bit, have a good relationship with your colleagues, because if it's not good, life is hard. I trained, my undergraduate degree was medical engineering, and then I did a master's as a physician associate at Anglia Ruskin. And then I did my general practice rotation in Brentwood, and I did my secondary care and psychiatry placement at Basildon Hospital. The course was very difficult, as are many people's courses. Having to cram everything in 2 years was very hard, and that's why I say that we thrive on learning from everyone, because we didn't necessarily get the opportunity to learn everything in as much depth as we needed to. So coming into general practice or coming into hospitals to learn from our colleagues, to fill in that gap of learning, is also very beneficial to us. We weren't welcomed by everyone. So like I said, some people did have the misunderstanding that we was coming to take their roles, and because of that, they didn't want to teach us. That was my experience at Basildon, that they didn't necessarily want to teach us because, number one, they didn't understand the role. Number two, they're seeing that we was coming to take jobs from people. And the aim was just to bridge the gap. It's just to help, because there isn't enough of us. Even if we employed as many people, there's still not enough, because people are living longer because medicine has got better. So as much as everyone's needed. If we're not here, it's not going to work. And because the course was new when I started, they still were working out some tweaks, I think, as every course is. So at the moment, I work in general practice in Bromley. I did used to work in Ilford. I do supervise physician associate students, medical students. We don't have any nursing students at our practice, but if they were there, I'd help supervise them as well. I do out of hours in general practice in Croydon, telephone triage consultations, as everything I'd mentioned in my previous slides. I have also been involved in health promotion talks with the patients, so allowing patients to come in and ask any and every question they have in regards to their long-term conditions, things that they don't have time to ask in their 10, 15-minute consultation. Physician associate talks like this one so that we can give more insight to people. And I also lecture 1 day a week to physician associate students as well. So at the moment, we just, like I mentioned, the future of physician associates is just to bridge the gap in the needs in general practice and in secondary care. And that once we become regulated, we'll have more access to more training courses, we can do much more and help support our colleagues much more. And then just there'll be more awareness. I still have a lot of patients. It explains to them what a physician associate is, and they say, okay, bye doctor, and bye nurse, or bye. So just hopefully there'll be a day that they'll just walk in and be like, yeah, I know what you are, and I know what you can do. And that's it for me.
Hello everybody, my name's Julie, and I just want to say a few things just before I start. I do have a learning disability, so if I pronounce words wrong or if I switch the slides too soon, please let me know and I will go back. I've been asked here today by North East London Practice Futures Conference because I believe I was one of the first nursing associates on the pilot scheme to finish. Today I'm going to speak about my experience of working in a general practice setting and studying to become a nurse associate, and hopefully answer some questions that I've been asked to answer. So as I said, my name's Julie. I've been working in the borough of Haringey since February this year. Before I worked as a nurse associate, I started off actually as a GP receptionist. And then when I got a bit, I need to do something else now, I went to do the healthcare assistant and did my diploma level 3. And then after doing that for a few years, decided I'd been working with nurses for quite a long time, and they had encouraged me for a good while to carry on and get something else and do something else. And I was a bit scared because of my disability. So here are the questions that I will try to answer as best as I can. So what was it like training as a nurse associate in a practice setting? It was good. I had loads and loads of support from the practice nurses, which was wonderful. It was a bit unfamiliar because our spoke placements were at hospitals, mental health, and in community settings. So it was a bit different from what I had envisioned it to be. But having the placements in these settings was a really, really great experience. I met some really, really wonderful people, and they encouraged, inspired me along the way, and I was able to take all my knowledge back to the surgery with me. And it really helped with the return to practice, as I was able to understand some of the procedures that patients were having. I then learned a lot about medications, what they were for, groups of medications and things like that. And I had a greater understanding of mental health and disabilities. And how do I support the nursing team? I support the nursing team in a different way now to the healthcare assistant. I have a bit of theory behind what I was doing, where before as a healthcare assistant I didn't necessarily have all of the theory that I needed. And so I now have a wider skill set, and I can take the pressure off some of the practice nurses to allow them to concentrate on more complex clinical care. And what are the benefits of having a nurse associate in your team? Reception feel that they can utilise my appointments more, especially with ad hoc patients. So if like someone comes in the surgery, needs something, they will call me and say, are you able to do this? And it will be either yes or no. And the GPs are happy to give me more challenging patients, which has proved a positive link between myself and the GPs. They've encouraged my learning and always been available if I'd had any questions. So there is a lot of work with the teams in the surgery, and we do have like pharmacists as well in our team, and it's been really good that we can work GPs, the nurses, the pharmacists, and anyone else. We don't have a physician's associate in our team, but we do have a physio, so which they have a specialist as well. What would I say to a practice team that wanted to employ a nurse associate? I would say it'd be a good investment, and it helps the nursing associate to advance their career path through training. And you never know, if they decide to do the top up, they might even become your practice nurse. So thank you very much.